Great to see you all. Thank you to Founders Pledge for having me. Nothing I can say to you today will tell the story better than that film does, Bending the Arc, and I encourage you all to see it. So let's start with a simple question. How much is a human life worth? If you had to, could you put a price on it? It's a simple question, but not an easy answer. Now let's go a step further. Should that price be the same for everyone? Is the life of a child here in London worth more than the life of a child in Mogadishu? Now, I hope you're thinking, of course not. A few of you might also be thinking, where the heck is Mogadishu again? I know, you're a very sophisticated crowd. You all know it's in Somalia. Now, these questions might sound cynical, but in public health, we actually make judgments like this all the time. There's a tool called the cost-effectiveness threshold that helps us determine how much we as a society are willing to pay to give a person a year of healthy life. Here in the UK, that figure's about £20,000. So that means if a medical intervention costs less than £20,000 to give one person a year of healthy life, the National Health Service will probably pay for it. How about in Somalia, the world's poorest country? Excuse me. Oh, missing a slide. That figure is about £200. Put differently, the life of a child here in England is worth 100 times more than that of a child in Somalia. Feeling uncomfortable yet? I hope so, because this is an uncomfortable truth. There's a disconnect between what many of us believe and what we do, or at least what we accept. As a society, we value some lives more than others. And that notion is at the heart of all that's wrong with the world today. It allows us to avert our gaze when a woman dies in childbirth in a remote village. It's the reason why 72 lives were lost at a fire in Grenfell Tower here in London a couple of years ago. It's the reason why children seeking asylum in the US were put in cages separated from their parents. The good news is, it doesn't have to be this way. We can flip the script and insist that all lives do indeed have equal value. The technical term for this is equity. And here's the thing. If we make equity an organizing principle, it can unlock new possibilities. I have proof, and it comes from an unlikely place, as you just saw, Rwanda. Now, it's impossible to understand Rwanda's story without revisiting a dark chapter, the 1994 genocide against the Tutsi that took 1 million lives in just 100 days. That's a rate of killing faster than the Holocaust. It tore apart communities and plunged the entire region into chaos. Now, many believe that the genocide was driven by ancient hatreds between two ethnic groups. It actually stemmed from colonial policies that pitted those two groups against one another, creating inequalities that made it easier for the colonists to rule. And those inequalities deepened in the decades after independence and then exploded in 1994. Most countries that experience violence at this scale never recover. The new government recognized this challenge, but they also had a really important insight. They recognized that desperate poverty and unequal treatment were actually the root cause, the underlying conditions that had made violence possible, that had made it possible to turn neighbors against one another. And so that meant that to prevent another tragedy, it was essential that no one was left behind. So equity became a national security strategy that colored everything that the country has done since. It was written into the new constitution as the country started to rebuild. Now, meanwhile, something else was happening halfway around the world that would help Rwanda change its trajectory. A little organization in Haiti called Partners in Health started one of the world's first AIDS treatment programs for the poor. So we're in the late 1990s now, when HIV/AIDS was running unchecked across the globe. In some parts of sub-Saharan Africa, including Botswana, where my wife was born, 1/3 of young adults were infected. Entire generations were at risk of being wiped out. This was just a couple of years after the discovery in 1994 of new combinations of drugs that could keep HIV in check, turning a death sentence into a manageable illness. The problem was those treatments were only available to those who could afford it. And that meant that millions were condemned to die simply because they were poor. Now, to be fair, these drugs were really expensive. $15,000 per year for one person. But that didn't make it right. Partners in Health was built on the simple idea that health is a human right and that all lives matter equally. And that's why PIH started in one of the poorest communities in the world. And that's why when effective AIDS treatment became available in wealthy countries, the only appropriate response was to offer the very same treatment in rural Haiti. Now, it's important to understand how radical this was at the time. The conventional wisdom was that HIV was too expensive and too complex for poor countries. It was just too hard. And I want to just divert here for a second because there's been a lot of talk about the importance of data and evidence in all of this work and the work that you do and the work we do, and that's absolutely true. But it's a two-edged sword as well, right? There was a very famous paper in the late 1990s in a big public health journal that published an analysis claiming that HIV prevention activities, which at the time consisted of giving out condoms and teaching abstinence, was 22 times more cost-effective than HIV treatment. And so actually, science was used to deny people access to treatment. And the data were there and the evidence was there that reinforced the conventional wisdom. That was totally debunked later on, but we have to be really careful about this stuff. So what happened was, based on the evidence, the experts said, we should just teach people not to have sex. Spoiler alert, it didn't work. But that was the zero-sum kind of utilitarian world of public health. We were told we have to choose between having facilities for safe childbirth or buying vaccines to keep those same babies healthy. We have to choose between preventing HIV or treating those already afflicted. We have to choose between malaria or cancer. But viewed through an equity lens, and I love that Jacqueline used that same term here a few minutes ago, viewed through an equity lens, those are false choices. When we say it's not cost effective, what we actually mean is that some people don't deserve the same stuff that we deserve. Could you look the mother of a sick child in the eye and say that? Equity forces us to think differently. Rather than saying no, we're forced to ask how. If the drugs are so expensive, how can we unlock more capital? If they're too expensive, the market must be broken. How do we fix it? If there aren't enough doctors, how do we empower other kinds of health workers to do the job? So you can begin to see how using equity as an organizing principle can really drive innovation. PIH faced criticism at every turn. It's the same guy called Joseph. They were accused of being irresponsible, naive, of wasting resources. But they pressed on, and that little HIV treatment program in Haiti worked. Everyone got better. And that program, and a few others like it around the world, stood as a powerful challenge to that status quo. And over the next few years, driven by massive worldwide social activism, everything changed. And suddenly, by 2003, everyone kind of seemed to agree that all people with HIV deserved a shot at treatment. It's one of the most significant sort of shifts in social norms that I've ever seen, certainly in healthcare. And that unlocked billions of dollars in new investment and drove down the price of HIV treatment from $15,000 per person per year to $100 per person per year. No one back then was asking, when they were doing the cost effectiveness analysis, who says it has to be $15,000, right? So in 2004, Rwanda was one of those countries that stood to benefit from the new HIV funding. The government, 10 years on from the genocide, real progress had been made, but there was still a long way to go. More than half the population was still living in extreme poverty, and most lacked access to even basic health services. During the genocide, HIV had been weaponized through a campaign of rape, and the epidemic was rampant. So in 2004, the government invited Partners in Health to come and help them introduce HIV treatment in some of the hardest to reach communities. I had started working with PIH a few years earlier as a doctor in training, and they asked me to come along. I stayed for 12 years. We were sent to the most remote parts of the country. No roads, no electricity, no hospitals, no doctors. We started in a village called Rinkwavu, which had a colonial-era hospital that had been abandoned since the 1994 genocide. So we brought care directly to communities, house by house. Those who were the sickest were offered treatment first, and those who were well enough to work were trained and hired as community health workers. And meanwhile, we started rebuilding the hospital as patients poured in. For a while, we slept on the floor alongside our patients, and that's how it started. Within a few weeks, 100 patients were on AIDS treatment, then 1,000, then 5,000. Now, it's important to note that HIV wasn't the only health problem facing these communities. 1 in 4 children at the time were dying before their 5th birthday. Just take a minute and think about that. The problem was there was money suddenly for HIV, but not much else. I vividly recall being in a community meeting where a man stood up and said, "I'm very sick with diabetes, and every night I go to bed wishing I had HIV instead, because then you can help me." Again, equity was the mother of invention. You see, to treat a complex disease like HIV or diabetes or cancer, you need more than drugs. You need functional clinics staffed with trained providers. You need electricity and clean water, pharmacies, laboratories. So if you resist the easy path of treating one disease in a silo, you create a system that can care for everybody. So while that HIV program grew, nobody else was turned away. Together with the government, we built intensive care units for premature babies, offered mental health services to those suffering trauma from the genocide, introduced cancer care, as you saw in the film. Together, we invested in water, agriculture, and education, because those things affect health too. 10 years later, the system was providing care for over 1 million people and creating thousands of new local jobs. And this was just one part of the story. Rwanda was setting up partnerships with little experiments like this all over the country. And when we found a solution that worked, we'd scale it up nationally. During the last 2 decades, life expectancy in Rwanda has doubled. It's approached the global mean, it's nearly 70. Access to HIV care is now universal, and our treatment outcomes for patients in Rwanda are better than in the US. Thank you. Thank you. Mortality for mothers and children has dropped by nearly 80%. And with one of the world's fastest growing economies, millions of people, literally millions of people, have pulled themselves up out of extreme poverty. Rwanda has delivered steeper gains in population health than any country in the world at any time in recorded history. Turns out that an equity agenda was not just morally sound, it was smart policy. Now, the funny thing was, when we started publishing this and going around the world to World Health Organization and big conferences trying to share these results, we were met with a ton of skepticism. Most of the experts said, yeah, it doesn't count. Rwanda's a special case. It's small, it's organized, they have a unique leader, couldn't be done anywhere else. And we called BS, right? We thought if Rwanda can overcome such long odds, this could be done anywhere. And that's when we realized that if we really wanted to change things, we would need to challenge the entire public health establishment, reimagine public health, and train a new generation of leaders who thought differently. Well, knowledge and education are the provenance of a university, so we started our own from scratch. And where better than Rwanda? It's called University of Global Health Equity, and it's just a few years old. We opened in 2015. But we've already trained students and public health leaders from around the world, actually in over 24 countries. Just actually a couple of months ago, we opened the first phase of a beautiful new campus on a hilltop. It's the beginning of something really special. And meanwhile, at the Skoll Centre for Social Entrepreneurship in Oxford, we're working to amplify this kind of momentum around the world. At their best, social entrepreneurs do just what Rwanda did. Identify an unjust status quo and attack it. Find opportunity where others see only obstacles or excuses for inaction, and then build better systems. We believe that social entrepreneurship is the most powerful tool we have to attack the world's most pressing problems, and the need has never been greater. We're living in a moment of contradiction. This is the best time in human history to be alive. But yet, there's also mounting uncertainty, right, about where we're headed. To change our trajectory, we need to think differently. And that's exactly what happens when we make equity our North Star. It expands our moral imagination, and all those excuses for inaction wither away. And then, like the people of Rwanda, we might find the audacity to imagine a better future and get to work building it. Turns out that dignity and hope are cost-effective. Thanks.